Hello, and welcome to the LME MCO Disaster Mental Health Training. This is a collaborative effort supported by the American Red Cross, the North Carolina Disaster Response Task Force, which is a multidisciplinary mental health group of professionals, the North Carolina Emergency Management, and the North Carolina Department of Health and Human Services. As mental health providers for your Medicaid managed care organization, you are about to observe a Disaster Mental Health and Shelters module that was based on the American Red Cross Disaster Mental Health Fundamentals 2 workshop. This is intended to apply the knowledge gained from the American Red Cross online course, Disaster Mental Health Fundamentals 1, which is a prerequisite for this workshop. The purpose of Part 1 was to provide an in-depth study of the knowledge and skills associated with providing high-quality disaster mental health services on a disaster relief operation. The primary purpose of Part 2 of Disaster Mental Health Fundamentals is to give you the opportunity to apply the knowledge you gained during the online training, including disaster mental health interventions. Become familiar also with the role of the disaster mental health worker. Both of these courses are part of your credentialing to be disaster mental health providers in disaster shelters. Although you are not official American Red Cross volunteers, your primary role in the shelters will follow much of the same expectations of the American Red Cross disaster mental health role. All shelters in North Carolina are now oriented to the American Red Cross model, and this role will be most closely fitting with this expectation. As paid managed care organization providers, however, you will also be operating under your professional license and follow the MCO protocols for necessary assessments and referrals of shelter residents for mental health treatments. The discussants on this training webinar are simulating a small work group as experienced disaster mental health American Red Cross volunteers. They are offering their reflections and insights to share what they have encountered. Here is a list of the functions and content of how a shelter works. There will be a team of volunteers in the shelter. There will be a leader who's a shelter manager, a shelter supervisor when the manager is off duty. And the shelter workers have many roles. They help set up the shelter, they move supplies, serve meals, and assist clients. There are additional roles such as logistics and public relations for other individuals that are working in the shelter. Disaster mental health is part of the team, and the related colleagues that you may encounter include disaster mental health, disaster spiritual care, disaster health workers, which include many nurses, some physicians, physician's assistants. Additionally, disability integration specialists are likely to be present. You will be part of a shelter team. You will volunteer to help with shelter tasks such as serving food and setting up cots if asked. And you will get to know other shelter workers, set a positive tone for mental health in the shelter. All shelter workers contribute to the emotional atmosphere of the shelter. And so this is very important for you to emphasize in your experience with meetings and individual contacts. And also, everybody in the shelter has had some level of training of a psychological first aid. And so that would be an example of where you can reference that, setting a tone when you have conversations. The major shelter tasks include welcoming, which are reception and registration, safety and comfort in the dormitory environment, food distribution and the dietary needs. There'll be communication and information sharing, and then, of course, setting up and closing down the shelter. The basic concept of the operation of the shelter is, for the Red Cross, is everyone is welcome. And this means all individuals with access and functional needs or disabilities are accepted in Red Cross shelters. This includes, but is not limited to, mobility impairment, visual or hearing impairment, developmental, intellectual, or cognitive disabilities. Disability integration, self-determination, is critical. So the need is to support client decisions regarding shelter placement. Here we see a graphic representation of how, although there is a subgroup of people that are formally defined as having disabilities, in a shelter experience, you can anticipate that those people will have access and functional needs, even though they may not have the designation of having a disability. The manner of assessing for these functional needs is called CMIST. It's a FEMA sort of checklist for functional needs, and this includes areas of communications, maintaining health, independence, service support, and self-determination, and transportation. The CMIST model provides a functional needs framework which assists workers with gathering and organizing information about a client's self-identified access and functional needs. And this framework supports the independence and self-determination of all clients, and for individuals with disabilities, discourages a medical model approach which tends to view them as patients. Additionally, North Carolina has a FAST team, which is a functional assessment support team that's available. This team works by supporting general shelter staff and preserves vital medical resources and frees up other emergency services. Not all shelters will actually have FAST team members. They will be requested through the Emergency Command Center and deployed directly to the shelter. It's going to be typically the shelter manager that would make this request. This emphasis here is on culturally competent services in a shelter. Disaster mental health services are most effective when assistance acknowledges and honors people in the context of their culture. And culture competence is being responsive to cultural concerns of racial and ethnic minority groups. So for a review of disaster mental health, the emphasis here is that no one who sees a disaster is untouched by it. Stress, trauma, and grief are normal reactions to abnormal situations. Most people pull together and function adequately in response to a disaster, but effectiveness is diminished, and this needs to be understood and recognized. Emotional reactions stem from problems of daily living that are created by a disaster. So this part of the presentation, we're going to move into the Red Cross model for intervention elements. This graphic representation sort of summarizes in this format how these are areas that interplay with each other. They are not independent, standalone features. And I'm going to go through, at this point, the part of the workshop which will engage our discussants. So we're going to have small group activities. We would have formed groups of three. There'll be three discussants, and they will answer these questions in a discussion format and share the answers with those of us of you that will be observing this training. And at this point, I will ask them to introduce themselves. Tatiana, you want to start?
Sure. I'm Dr. Tatiana Kolodkov.
And can you tell us a little bit about your background and what your experience has been?
Sure. I do disaster mental health with the Red Cross, and I'm the co-chair of the North Carolina Disaster Task Force. Otherwise, I'm a psychologist with a private practice in Durham, North Carolina.
And in recent North Carolina disasters, you had some experience in sheltering. Is that correct?
Yes, that's correct. I was involved both with Matthew and with Florence with the operations.
Okay, thanks. And Therese, do you want to introduce yourself?
Yeah, sure. Hi, my name is Therese Garrett, and I am an adult, child, and adolescent psychiatrist, and I work with some of the MCOs through my job at a community mental health agency, and I'm also a disaster mental health volunteer for the Red Cross.
And your experience recently in North Carolina?
Yeah, so I've been involved in both of the recent hurricanes, and most recently was involved in two ways. One, through disaster sheltering work, and then also through the Red Cross, so got to do a little bit of both pieces of that.
Great, thanks. And then finally, Judy, can you tell us about yourself?
Sure, I'm Judy Nicholson, and I have been involved as a disaster mental health worker with the American Red Cross since 1995. I have worked my way up the chain, if you will, in disaster mental health, starting with working in shelters with clients, and have been involved probably in every major hurricane or disaster relief effort since the 90s, including Floyd, Fran, Florence, and Matthew. And I'm a clinical social worker, retired from practice, but still volunteering with the Red Cross.
Great, thanks. Well, we look forward to your shared wisdom here as we go through these questions. So under the elements, first element is identifying mental health needs, and the question here are, what are the 3 R's? So I'm going to facilitate by having the first one, reactions. Can you all say something about these?
Yeah, this is Judy again. I have I believe that it's really important to keep in mind with regard to reactions of our clients in the shelter, paying attention to not only what they're acting like and saying, but just asking questions and finding out sometimes just in the observing of their day-to-day interactions with each other, and noting that these reactions to being in a shelter, to being having been affected by the disaster we need to keep in mind that these folks come in with pre-existing issues and life situations. So not making any total assumptions that what they're seeing is actually a reaction to the disaster, but in fact what they've come in with.
Okay.
So I think another piece that I try to attend to is that situations are the ones that are externalizing or acting out kind of behaviors, or folks that are appearing quite distressed, and not the folks that might be more quiet or withdrawn. And so I try to sort of make sure that I'm getting, surveying what things are looking like for everybody, to see if there are people that might seem more disconnected, that would otherwise sort of fade away because they're not causing any problems and they're quietly sitting on their cot all the time, or whatever it might be. And just making sure to check in with some of those folks too, because their internal reaction may be very different from what we're seeing on the outside.
Good point.
When I think about reactions, partially what I'm keeping in mind is what I might be seeing may be completely normal given what the client has gone through, given the fact that they're living in a very disrupted life rhythm and a setting that might be very uncomfortable for them, and not to over-pathologize or over-attend to if a person is having an intense reaction. But obviously, that's part of our role, is to be keeping our eyes and ears open and observing what there is to see. And also that those reactions look differently across the developmental lifespan, that, in a way a child might be responding will maybe look very different than a teenager, or a child might, for example, be resorting back to having accidents again, and a teenager might be, even if they've returned back to school, might start skipping class if they've never done before, and that might look very different than the reaction of an adult.
Very good. Can you say something, Tatiana, more about the risk factors, the next star?
Yeah, I think, risk factors are not unlike the ones we might encounter in other clinical settings that we need to pay attention to, but the way that a disaster situation may impact a person depends on some other factors, and one of those being social support. Obviously, having to evacuate where you live and end up in a shelter can cause a huge disruption to an entire system, and that's just one example. As risk factor could be isolation that was pre-existing, or one that's taking place now in the setting that they're in.
Good point.
Yes, risk factors go, I believe that kind of harking back to my comments initially about reactions, risk factors have to do with what they may be any pre-existing conditions, or like Tatiana said, any type of support, or cut off communications from their normal support systems, and just general knowledge of how prepared or not prepared they were, what is going on with regard to their. A risk factor may be not knowing what's going on with the rest of their family. If you start thinking about being a disaster survivor, then you think about what it is that they don't know, and that can really tip somebody into a more stressful state of mind. Yeah.
Well, and then I think another piece that I would want to pay attention to as far as risk factors is any either underlying pre-existing medical health-related conditions or any health conditions that could be about your mild or major injury from something, and along with that, in terms of the risk factor, if they do have either a pre-existing or a more acute condition, do they have whatever treatment that they need for that, in order to try to limit that risk factor as much as possible, depending upon what it is that you're seeing in that situation.
Very good. How about resilience, Therese? Can you say something about that?
Yeah, I mean, I think as far as resilience, a lot of this kind of goes back to what Judy was saying about some of the, both Judy and Tatiana were saying about some of the support systems, and, looking at both individual and community support. So if you're in the shelter, are folks there alone, or are they there with family or friends? Or if they are there alone, do they seem to be sort of building some connection there? What are the in terms of working right now, and what are some more internal aspects that allowed them to get through any challenging situations that may be some of the internal resilience factors separate from external support.
Yeah, we don't often see, on their faces or in the first few days of being in a shelter, necessarily see what they've been through or know what they've been through, but just observing the way our clients have been able to settle in and sometimes just reach out and help their cot neighbor is usually a good indication that that they come with some resilience and when it's also important with regard to resilience to help them notice themselves that they've got what it takes to get through this.
Okay, now we're going to go on to element 2 here, which is a promotion of resilience and coping. And so I'm wondering, can you all give examples of how to use psychoeducation? And we'll quickly pull up the full list shortly.
I think one example of psychoeducation that's helpful is to normalize reactions. And I find that sometimes people are very reluctant to talk about what their own experience is, but it's much easier to ask them, how is a loved one coping, and are your kids having an okay time sleeping at night? And then they start talking about other people's experiences, maybe indirectly sharing their own. And so explaining to them that some of the things they're going through are what's expected and normal, and how they might be able to return to normalizing their routine, which would support their physical and emotional health.
Very good.
I agree with Tatiana. A really, I've found effective way to use this psychoeducation is just very ad hoc, very casual, but even in a group, like when people are eating together, talking about what's normal and getting the discussion going about, oh yeah, my baby was just been tugging on me. Yeah, me too. And then you can kind of add in a little bit more about that normal and what do you do with that, and get it so that people are seeing that others are are having some of the same reactions.
Good.
Yeah, demonstration is really an important piece, especially with children and youth and falling back on milestones, because I think folks very quickly go to, oh my gosh, there's a real problem. My kid has started bedwetting again, or is wanting to be carried all the time, or whatever it might be. And I guess that's a difficult job, to be back in that stage. And it's, possible that this may be temporary. What are some of the ways that we can support resilience? What are some of the ways that we can kind of help support the return to any sense of normalcy or routine, even within the chaotic environment that a shelter can be?
I think another part of the psychoeducation piece too is just to help maybe clients think of the very first step or one small action they might be able to take today that might either help them feel better or start making progress in their recovery.
Yes, keeping it on a day-to-day basis rather than catastrophizing or oh my goodness, what am I going to do for Christmas type of thing. It's really important to help people stay in the now as much as possible, and then just the very next hour or next day. That's a good point, Tatiana.
And then having materials like brochures, I gather, is another additional thing you can do if it's hard to engage people with these conversations.
Yes, there's some pretty good material out there. I like to make sure I take a scan at it too and see what's what, and point out the major points. Sometimes something written will help people remember what was just said, because as we all know, that the stress will keep people sometimes from being able to maintain information, and if it's written down, that's helpful.
Yeah, good.
Also, having information in different languages, or having information that people might otherwise perceive as difficult to take in, like a crisis phone number. If you just hand that information on a piece of paper, sometimes a person may be more receptive or just able to interpret it in a language that you're otherwise not able to communicate in.
Right, good point. So moving on to the next area, we're looking at the elements of enhanced psychological first aid. I'll throw up the list, but you guys want to start a conversation about the highlights of that?
Sure. Well, I wanted to start by, I think the very first piece is, how do you connect with a person? It's so different to meet with a client when they're in a shelter environment than when they're coming to you on their own terms for a scheduled appointment in a private office. So finding a way to just maybe make eye contact or start a casual conversation, ask them some element of what they're doing, and that is the first piece, and that might involve coming down and squatting on the floor to engage with a child, or approaching someone and asking them about how their morning went, or how did they sleep last night, can just be a start to the conversation.
Yes, I agree. At the beginning, for me and for a lot of the folks that I've worked with, and mental health professionals, your point is so well taken. People come to us, and so this is total opposite. We find our clients where they are, and so making yourself available, even if it's assisting with somebody getting settled into their cot, or helping them carry a meal to the table, that kind of thing can be a real good communication opener.
Right. Really, the starting place for all of this is starting from a place of just being human and being compassionate, and trying to help identify what might be useful to someone in a situation, or just trying to build that connection. Are you able to or something? And if you are trying to talk to them in the big shelter room where people's cots are, if it's somebody who's older, are you able to make sure that you're speaking slowly and loudly enough that they can hear you and aren't distracted by some of the other things, if there are any hearing difficulties, or if there's someone who might be more overstimulated, trying to find out whether they want to talk, but might want to find a place that's a little bit quieter. Again, it's not going to be as quiet and ideal as, you know, someone coming into your office for a therapy appointment or a psychiatry appointment, but you kind of make do with where things are and try to sort of find and make folks as comfortable as possible and try
One of the
to yeah.
I'm sorry, there was a glitch in the sound. Go ahead. Well, okay. One of the points on the slide is giving accurate and timely information. I have found that unless you have verified something like this center is open for assistance or this food bank is open for food, unless you have verified it within that day or even that half a day, don't give it out unless you know that this is accurate. It's just a more of a stressor and kind of devalues your knowledge and your helpfulness if you're not accurate and timely with information you do give, and including making referrals. Sometimes it's easy to say, well, this so-and-so clinic is seeing people, but if you could help them through a process of making the referral, especially if you can engage them yourself, that's helpful.
And as mental health individuals in a shelter, you know, we can use great problem-solving skills and creativity to try to promote good coping. Maybe rather than talking in the middle of the room, you know, we invite the client to go outside and maybe we take a stroll together and maybe they feel a little bit better from that. Or maybe we can remind them that if there's somebody that they're used to calling every week, that they return to calling them. Establishing within an unfamiliar setting something that might be helpful that makes them feel a little bit more restored or just maintains a sense of clarity and hope.
So it's, you know, in terms of this comment about good coping, that would make a point in terms of the last item here about taking care of yourself, not to forget also, you know, what your needs are along with the clients, right?
Definitely. That's one of the things I've learned over the years is to notice my flags, my signals to myself where I'm getting a little bit edgy or not as effective as I am when I first start this work. So notice my flags, and then also what works for me is taking a walk around a building, going and sitting down and being quiet and being away from people, calling home, stuff like that. Just so notice your flags and then what it is that helps you to kind of regroup.
Great. So we're going to next talk about targeted interventions for clients. And there's a series of 4 different areas that we're going to comment on. Although the official word is for high-risk individuals, it's important to say that you don't necessarily know altogether what the risk is for individuals. So that as a general way of thinking about these kinds of supports and services for clients, these are areas to consider. So we're going to start with the elements of crisis intervention. Folks want to chime in on that, their thoughts about that?
I think a part of crisis intervention in a shelter is to try to assess the situation and see how it might be possible to de-escalate the situation as quickly as possible using the resources that are maybe already immediately available, because the whole community is typically taxed, and so we may not be able to have even options that are familiar to us. But that's partially what comes to mind. We're thinking about something that's time limited, but also has maybe a specific focus on what's going on right at that moment and for that person rather than solving a bigger picture situation.
I mean, I think one of the things that is unique and different to crisis intervention in this setting, again, is the fact that any intervention you're doing is still in this large and busy environment. And so, you know, some of the de-escalation piece, sort of working within what you have to try to find maybe some quieter places, maybe some places, how you know, be aware of what impact a certain situation might have on people who are not involved in those situations, because again, these crises aren't in your office or in an emergency room or in any other sort of a controlled setting in the same way. I think the other piece of that's really important is that or one-on-one work is that it is very brief and time limited, and that you may be meeting with somebody just once or twice or maybe 3 times, but this is not something where you're going to be doing an ongoing work with the person. And so, you know, you don't necessarily want to be getting into a trauma with them, because that's not what the work is within this setting.
Yes, it's staying in the moment. It's starting where the client is, right there, not the history and not the what's going to happen in the future. The time limited thing can be a little bit tricky if you are assigned to the shelter, because yes, you may have 2 or 3 contacts with them particular to the crisis at the moment that they're having. And when once you maintain equilibrium, you may be seeing that client again, you know, day after day with a nod and a smile and a how you doing. So, but that focused intervention will be just to help them get their feet underneath them again.
Okay, so we're going to look further here about how you might refer a client to a community agency that includes the LMEs or the MCOs. So there's secondary assessment and referrals, and the question here about when to refer to these community resources. So you guys want to talk about that?
Sure. So I think one of the first one would be going back to the crisis intervention, evaluating and determining when someone might be in a true mental health crisis that they need any further assessment, whether it's through mobile crisis or it's through connection to the emergency room. Are they in a place where their own safety or the safety of others is at risk, that they're going to need a more formal, immediate evaluation, knowing the community we're in, being called from, you may be in the county but you also may be in a county that you have less initial familiarity with the sort of mobile crisis services within that region, finding and knowing some of that stuff before you're in a situation that you use it.
Any discussion here about the issue of medication?
Well, I'll pipe in here because that will always come up. We will find, in crisis situations and disaster evacuation or post-disaster sheltering, people will have been out of their meds or almost out of their meds or in need of medication. As a social worker, that to me is just a walk over to the health services person for them to then they are tasked with if it's refill or something like that, they will take the lead on it. I don't speak to specific medications from my clients. That's all up on the health services side.
Mm-hmm. Grace, do you have any thoughts? Oh, sorry. I see you've gotten a bit of technical problems. Tatiana, you still on?
Oh, so please, I'm on. Did you ask a question? Because now I can hear you.
Oh, okay. It had to do with the medication?
Again. Sure. Yeah, I think obviously I can evaluate some of the information about folks' medication well, and oftentimes some of these situations are actually very simple in that there have been some times when I've been asked to just take a look at someone's medications to see if they are taking them in the way that they're supposed to be taken. Also, when there are folks that are coming in and saying that they're out of controlled substances, I'm able to pull some of that stuff up in the state database to see, whether that's true or not, and when they might have filled stuff, and whether they even have an active, whether they have recently had an active. So that can be helpful. The other big piece that I've come across in medication is for health services when they're working in terms of getting retail medication, because injectables are not things like, hey, I have this thing that I need refilled. Trying to find out whether they're supposed to be on a long-acting injectable medication, and if so, are they due for that, or when were they due for it, and are they supposed to, and how can we sort of move forward to ensure that they get what they're actually going to need?
Okay.
And sometimes there's also disaster-specific support groups. So just as an example, after the Durham explosion, there was a group that was organized for families of the school that was across the street. And sometimes you can get information about things that are happening and pass that on to clients so that they can maybe access those resources beyond the services that are being provided to them in the shelter.
And also in the shelter, there's not been a time when I or another mental health worker have reached out to Alcoholics Anonymous or NA to see about either giving rides to people to meetings or actually setting up meetings in a private, quieter place in the shelter.
Good point. I would myself just add to this discussion that the question of immediate hospitalization, I would let people know that you can always call 911 if there's an immediate crisis, somebody's suicidal, or they're so psychotic they seem to be unable to function adequately in the shelter. Disaster Health Services, depending on the size of the shelter, can help facilitate that. There may be an EMS ambulance that is assigned to a shelter if it's large enough, and certainly there are access to law enforcement in different forms, state police or local police, sometimes National Guard that can assist you. So the point here is that you're not alone in trying to sort some of these problems out, but these are resources that are available to you.
Sometimes also we might encounter clients that need additional advocacy beyond what might be our role or roles of other individuals in the shelters, and so we can refer them to agencies that might be able to support them. Let's say they have a challenging immigration situation that they're in the midst of, or some, again, functional access need isn't being met. They're disconnected from their social worker at the VA. Those are other kinds of referrals with partnerships or maybe pre-existing partners even we could make.
Yeah, that's a good point, Tatiana. The VA has been standing up some very good disaster. They have a disaster group they're very responsive when veterans are identified. We can connect them with somebody that's of that group, and they can go from there towards their recovery.
Well, that goes into casualty support, which is really an important area also. And so I've quickly pulled us into the list of areas where these can be addressed, so we can move our discussion into that. That would be good at this point. That's
Red Cross responds, of course, to mass casualty incidents, but there are also cases where there, of course, have been death or serious injury to family members of people who are actually staying in the shelters. It's really important to be able to identify who those folks are so that we can focus some specific things such as our condolence team and some the Red Cross's condolence team, and the kinds of resources that they might have specific to people who have folks in the hospital or who have lost people.
It's a good point to and remind us that we have also disaster spiritual care individuals that are often available. So in these types of situations, spiritual issues are often prominent, and they can be additionally addressed with support of those individuals.
Yeah, that may apply to disaster workers. I'm sorry, I'm piping in again. That has happened in the case of we could have a shelter worker who has just had a family crisis, a loss of a loved one, perhaps at home, in which case we as mental health workers in that shelter will wrap our arms around them, so to speak, and try to get them supported and on to where they need to be in the most expeditious way, with compassion and emotional support.
I'm glad you brought that up, because I think one of the areas that disaster mental health, certainly in the Red Cross model, particularly in the beginning, was emphasized was the care of other staff members. And there is a way in which the Red Cross and shelters generally can provide staff support. So there are, through both disaster health services and disaster mental health, ways in which staff support can be more distinctly offered. And that's in addition to, obviously, the self-care, peer support that we need to provide for each other. Tatiana, thoughts on this?
Yes, I mean, I think what the Red Cross does with the Integrated Care Condolence Team, which is a multidisciplinary team that attends to families and tries to make a visit to offer condolences, and also to provide maybe some other forms of caseworker assistance to them. I think that that's a wonderful thing that that's in place. But, as a mental health worker, encountering a client who's experienced death in the family, it's important to know that line between maybe helping support them and get them some sense of containment, but not getting into grief processing. That would be an example of something that would be an outside referral.
Very good. So finally, we're going to look at the features of advocacy, which is in element 3, and maybe we can start our conversation with these points here.
My biggest oh, go ahead. Go ahead.
I think one of the things in terms of working with folks is that needs that folks have before. There are people who have needs that predate the disaster, and oftentimes in some more disadvantaged communities, those mental health needs or have not previously been addressed. The advocacy can be working with folks to try to talk to them about what might be some of the processes moving forward in terms of connecting them to services, or what might be some of the barriers that have gotten in the way of those, and are there ways to support their connection to some of the ongoing services that they may need once they're no longer in the shelter.
What I hope people keep in mind, other mental health workers and spiritual care, health services, everybody that's working with the client, it's important to ensure that our job is to help people engage in the process of their own recovery. In other words, doing it for them is not getting them their feet underneath them. That's just, maybe leading to more helplessness and confusion. Our advocacy in any way, shape, or form is always with the goal of getting in touch with that resilience that they have somewhere there, and hooking that into them experiencing themselves as having some abilities and power to go forward.
In reality, advocacy can be something that shows up in rather seemingly small ways, such as if you find out that a client is concerned because the diet being served to them is not consistent with their religious beliefs, then it's bridging that gap and making sure that they can get a meal that's nutritious but compliant with their religious observances. And then, we may encounter clients that in many different ways are disenfranchised or marginalized and already may need additional support with advocacy compared to maybe other clients' needs. And thinking about that can really help the way in which we approach people and how sensitive we are to the particular concerns that are relevant to them.
That's a very important point that you made, Tatiana, and I think that the complexity of certainly trying to provide culturally competent services in the realm of advocacy reminds us that we need to work with larger groups and not just a single individual. It could be the families or it can be other representatives of in the community of the specific ethnic or cultural group that the individual may be from. So I'm glad that you brought that up. Well, at this point, this is the end of the main presentation. There will be other opportunities for individuals observing this training to continue with that effort. The Red Cross does provide additional trainings related to mass care, integrated condolence teams, and other areas of particular interest that you might have. And your managed care organization can help facilitate that through other areas of training that they offer. So once again, I want to thank you for your participating in this online training.